Hi, everybody. Mitch Stripling back here for the third of four talks about public health emergency management. As a reminder, I'm a public health practitioner, and I'm here in this talk going to talk about COVID-19. My first talk was about the history of public health emergency preparedness and response, or FEPR. The second talk was about sort of the underlying capabilities and legislation and programs about it. I'm going to talk about COVID now, and in the fourth talk, I will talk about some public health ethics and decision making, including crisis standards of care. So let's talk about COVID. I don't have any sort of graphics or visuals for this. I just want to say, by way of grounding, today's September the 8th. So far globally, there have been more than 27 million cases of COVID-19, 897,000 deaths, about 18 million recoveries. Within the United States, we've had 6.3 million cases, and our death toll right now stands at 189,000. Just want to note the average age of death for somebody with COVID is over 65. That's the majority of people are 65 and over, but there's a wide skew of cases. There are usually chronic conditions associated with COVID, but that's true of any kind of respiratory illness. That was true of the 1918 pandemic as well. So we are dealing with a very infectious, tough disease. And it's notable that when you talk about all the planning and preparedness that we've seen for the last 20 years, that the United States has done so poorly at responding to COVID-19. And I'm not trying to say that as a partisan thing. I know a lot of this stuff is being spun up in the media, but as a public health professional, there are certain clear metrics that we have in the profession related to the capabilities that I've been talking about. And we've done poorly across most of those metrics. So let me sort of ground that and talk about how. And to focus this, I'm going to assume a couple things. I'm going to assume that you have a baseline knowledge of news about COVID right now. Again, it's September of 2020, where things are and where it's come from. In late 2019, it arose in China. There was an initial outbreak in Wuhan. It moved to Italy and other places while the United States tried to close borders. And eventually, we saw outbreaks and substantial amounts of cases here, all that kind of general history. What I want to do is focus on four capabilities, and let's talk about an assessment of each one. First, we're going to talk about non-pharmaceutical countermeasures, in particular masking, and how that's worked. We're going to talk about the healthcare surge and look at some issues surrounding that. We're going to look at test, trace, and isolate as a capability, and then finally, we're going to sort of look at risk communication as a sort of way to tie all those issues together. So, it's important to note that a lot of the initial response to COVID in the United States, in terms of the epidemiology, the initial blockage of airlines and all that kind of stuff, it is debatable. Certainly people had strong opinions about it at the time, but it is primarily fine from a public health perspective. We did the things that were part of the ASPR, Assistant Secretary for Preparedness and Response Playbook, as we've talked about before. We started hitting some issues with the non-pharmaceutical countermeasures response in terms of masking early on because of this sort of famous distinction that people have now, which is that at the beginning of the outbreak, public health officials like the CDC Director Robert Redfield, Dr. Fauci of the National Institutes of Health, sort of said the general public did not need to wear masks in February and March. And then later on, that guidance was changed to say that the general public did indeed need to wear masks. And that distinction in that non-pharmaceutical countermeasure has caused a lot of problems throughout the country, a lot of political backlash. So I want to sort of dig into it and talk about what happened and what it shows us about the public health response. So first, there are three types of face coverings that we're dealing with. It's important to lay this groundwork. Some people know this better than I. If you're an EMT, you probably have this down. But we've got face coverings, so the cloth things that people are buying right now that they're wearing, multi-layer cloth things. Those are really face coverings. Masks are something like a surgical mask or a procedure mask. Those are generally specific to healthcare. And so we reserve the word mask for them, because if you're talking about mask shortages or that kind of thing, masks are in a healthcare setting. So it's a helpful distinguishing feature. Something like an N95 that's designed to filter particles. That is a respirator. So whether it's an N95, which you tie on, you know what they are. I'm not going to describe them. Whether that's powered or unpowered, that's considered a respirator, and that's what really filters particulates, whether that's dust or small micron-sized things like COVID. So what we usually hear is that the reason for that mask distinction was that the science sort of wasn't there. Like initially, we didn't have the right science to show that these things would be effective. That there was a shortage of masks in the healthcare sector, and so we needed to sort of preserve that shortage, and that's why people didn't want the general public to wear masks. And then there was concern about the effectiveness of masks for the general public. So let's kind of look into most of those things. So in terms of the science of masking, one thing that's important to realize about public health response is that it's done differently in countries all over the world. Many Asian countries, especially those who had a lot of experience with SARS, this severe acute respiratory syndrome that we talked about last time, built mask studies into the scientific response to SARS. Now, COVID-19 is the disease that you get based on an actual illness vector, a viral agent that's called SARS-CoV-2, because it's essentially the second version of that severe acute respiratory syndrome, which was also a coronavirus. So the thing is that when you say the science didn't keep up with it, there had actually been a lot of Asian studies that showed that masks were effective in the general public for controlling COVID-like illnesses. Taiwan is notable in that in 2019, in December 2019, as soon as it heard about this potential coronavirus in China, Taiwan invoked their version of the Defense Production Act and started working overtime, making masks for everybody for precisely this reason, because they had good data to show that. The important thing for us is that that data did not cross into the Western context, because in the United States Public Health Emergency Preparedness and Response, or FEPR system, we have no sort of evidence sifting and grounding process to look at global evidence and link that into best practices. It's a real flaw, and sort of we saw the impact of that in terms of this confusion about masks. Secondly, the shortage of masks, absolutely. There was massive PPE shortage of surgical masks and other supplies like N95s in March and April. Partly that was because we did not invoke mask production like Taiwan did earlier on in the epidemic. But it was also because we didn't make a crucial distinction between these healthcare masks and the cloth face coverings that have now become more prominent. And the reason we did that is tied to reason 3, which is this idea that masks would not be effective for the general public. So public health experts in the United States were accustomed to thinking of masks as something you wore to protect yourself. And so they were looking for studies that showed the efficacy of masks to protect the person wearing the mask. Even though even in a hospital suite, a surgeon wears a surgical mask, not so much to protect themselves, but to protect the patient from their own germs. Like that's the point of a surgical mask too. But for whatever reason, even the most notable public health experts really weren't thinking about masks in that way. So certainly there was a shortage of masks. And in other countries, what happened is the leaders in the public health field began to ask for the ramping up of cloth mask production. Everybody make cloth masks. A lot of that happened in the United States anyway, because people kind of jumped on that bandwagon, but there wasn't a concentrated leadership push for it. Part of that, again, was going back to reason 3. People didn't think they were effective for the general public. That was because, in large part, people thought that if experts thought that if you were to give masks to the general public, it would make them overconfident. They wouldn't follow through on other social distancing recommendations because of the masks. So that violates one of the core tenets of risk communication that we'll talk about at the end, which is you've got to sort of trust your audience. You trust people to do the right thing, and you give them the right knowledge accordingly. Because we didn't understand the latest in global health research, because we didn't address the shortage of masks by asking for more production of cloth face coverings, and because we didn't sort of trust the general public to follow recommendations with sort of logic and common sense, it created this sort of divisiveness around this non-pharmaceutical countermeasure that didn't really need to be there and that other countries haven't really seen. And so a couple things about that. At the end of the day, there have been a lot of new studies, May, June, about cloth face coverings. We know that because of the way COVID works in particular, because of the size of its particles, a cloth face covering will block your exhalation, right? You're blocking exhalation, you're blocking droplets, but it's also catching a lot of aerosols. We were dealing with a rhinovirus, for example, it has smaller particle sizes. Cloth face covering might not be as effective, but because of COVID, they are pretty effective. A lot of this came down to a debate in the scientific community between aerosols and droplets. What is a disease spread by droplets? So you cough or sneeze and these big kind of balls of liquid come out, versus aerosols, which are smaller particles, 5 microns or less, that kind of hover in the air. This is one of those distinctions without a difference that's kind of ultimately meaningless. Anything that floats in the air can infect you. We knew, from January to February that COVID floated in the air, but because of the public health community's desire to anchor around this droplet idea, masks were sort of less important. Even as of this recording in September, the World Health Organization still hasn't sort of acknowledged droplet transmission, which is clear at this point that if masks are helping as much as they are, it's because you're dealing with, WHO hasn't acknowledged aerosol transmission. Since we are seeing that masks are efficacious, that means that COVID has hovering aerosols. That kind of goes with the territory. And so we're sort of learning as we go the importance of masks and knowing that COVID does have aerosols 5 microns or less that are hovering in the air, that if you exhale, your exhalation is going to keep those from going everywhere. And also anything you wear is going to provide a certain amount of protection against them. That's a lot of complicated stuff. The key point that I want to give you about masks as a learning area is that public health didn't have a good coalesced view of the global science, didn't trust the public, and also didn't sort of look for creative solutions when a PPE shortage appeared. Now, I'm a public health professional. I put myself in this camp. February, March, I was going on this same journey. But it's important for us, especially, to get an evidence base and keep that evidence base, which is one of the things that you read about in the National Academy briefing book that I gave you. So that's sort of my story of masks and face coverings. So let's talk about a slightly brighter story, which is healthcare surge. One of the bright spots to me about COVID has been that by and large, the healthcare system throughout the United States has really stepped up for it. Hospitals instituted surge plans. They instituted isolation wards. They put out guidance. They connected in surge networks. New York City, for example, put in a surge network between their public hospital system and their private hospital system to help with bed balancing, so that if you had overflow here, those folks could be routed to another place. And so I'll say that within a hospital or in sort of hospital neighborhoods, we really saw people step up and act like the professionals they were. There are 2 learning points about healthcare that I want to focus on. The first one is a learning point about learning, which is our ability to research. So what other countries did, Great Britain, Ireland, the European Union, they were able rapidly to put massive consolidated research programs in place that combined the findings from patients at a lot of hospitals across Italy, France, Spain, within the National Health Service in the UK. In our context, because of the privatized nature of healthcare, each hospital put in place its own research protocols. And so even when these big donors like the NIH, the Gates Foundation were sort of pouring research money into COVID, a lot of research was happening. It was mostly small bore research on small groups of patients. And that meant that we didn't have sort of a consolidated learning approach. So a lot of the things that you've seen about the sort of HCQ stuff when folks were really pushing that malaria treatment as a possible COVID treatment, a lot of money went into that really didn't need to, because there wasn't sort of a unified strategy for research, even after the WHO and others had determined it wasn't that effective. You might have heard that dexamethasone, which is a steroid, which can help people get out of the hospital more quickly, or convalescent plasma or proning, which is the idea that instead of having someone on their back, you put them on their stomach and it helps them breathe better. These methods were great and helpful. They didn't come from the sort of innovative United States healthcare system. They mostly came from these larger groups of healthcare systems working together to sort of learn lessons through research and then disseminate that. So the healthcare system in the country on a hospital-to-hospital basis has done a great job surging and taking care of patients. We haven't been able to work as a collaborative entity in the way that, for instance, the ASPR regional healthcare model asked the healthcare system to. And the other thing to talk about in terms of healthcare, which is especially tragic, is the question of nursing homes. So nursing homes are one element of that healthcare system, which is specified in all of the ASPR medical surge playbooks. But nursing homes, famously in the United States, are often underfunded. They are not necessarily well run. They're not subject to the same regulations as other healthcare institutions. We saw that in New York City in Hurricane Sandy, Hurricane Irene. People in nursing homes were often trying to offload their patients or care for them in subpar ways, and it became a real health issue. Now, in this case, nursing homes in the United States account for about 40% of deaths in COVID so far, which is a huge, massive number. And most of those deaths can be attributed to poor performance within a nursing home at infection control. Like, for instance, a study in Connecticut found that in Connecticut, about 70% of their deaths from COVID are attributed to nursing homes, so even a much higher number than nationally. And they found that for-profit nursing homes had 60% more deaths from COVID than not-for-profit homes. Nursing homes that had prior complaints lodged against them had higher death rates. Nursing homes with not enough staff had higher death rates. And so what we learned is that a well-run nursing home that was well-managed and well-resourced could do a really good job of controlling COVID-19 outbreaks. But if you had nursing homes where staff were bouncing from facility to facility, they were understaffed, they couldn't afford PPE, they didn't have good ventilation system, then COVID would spread like wildfire through those facilities. So this is kind of the backdrop for a number of states' decisions to offload COVID patients, recovering COVID patients from hospitals into nursing homes. So Governor Cuomo in New York made a decision to offload patients from hospitals into nursing homes. Now, that decision has come under a lot of criticism. The fact is, when it happened, New York was on the verge of a massive healthcare overload. Those beds were in short supply, and they were about to be overloaded by possibly a factor of tens of thousands. And so you had to move some of these recovering patients out in order to bring other folks in. What the data shows us is that when you move those recovering patients to a well-run nursing home with good protocols and PPE, generally things were fine. But when you move them to a poorly run nursing home, your death rates really skyrocketed in, again, tragic ways. And so how you manage in a public health emergency really does matter in terms of the mortality and the morbidity you're dealing with. Now, was that the right decision? There are other ways to do this. You can establish alternate care sites for recovering COVID patients, but at that moment, nobody wanted to take those patients. This was before the Javits Center. This was before we had bed balancing facilities come on. But nursing home deaths is really one of the weak points of COVID. So third thing I want to hit, test, trace, and isolate. So the laboratory testing and diagnostic capability within public health preparedness is so important because this is how you stop outbreaks. We talked about how test, trace, and isolate was sort of born from the fires of Ebola. And early on, the United States made a lot of progress in this. Apple and Google even announced a partnership to develop new kinds of software that would be secure, that would be based on blockchain privacy. The idea being that your smartphone could walk by another smartphone, and if that person was tested for COVID, you could be notified and you could be traced as a contact without anybody ever knowing sort of who you were or where you had been. So we got to keep our civil liberties and privacy. At the same time, we could stand up electronic contact tracing. Now, in other countries, in Switzerland, for example, 35% of the population as of now, as of September, has these apps in their pocket. They're using them all the time. In some cases, Ireland, it's even higher than that. In our country, it hasn't worked out that way. South Carolina, first let's talk about why. So when Apple and Google put this technology together, they couldn't, because of the way federalism is structured, look at a national system. They had to allow sort of code to go to every state, and then each state could sort of build a separate app based on their code. And those states, though, didn't have a mechanism of talking to each other. So if you were a tourist that went from Massachusetts to Colorado or something, or probably we're not flying to Colorado right now, Massachusetts to Vermont, you couldn't be traced, right? Because the states wouldn't talk to each other. That meant it was really reliant on every state's public health department to figure out a solution. Some of those states got really worried about privacy despite the blockchain encryption. South Carolina, for example, banned any attempted state digital contact tracing. They wouldn't let their agencies do it based on technology, because they were worried about being surveilled. They were worried somebody was putting a camera in their pocket. Part of this was because there were a couple of early contact tracing attempts that were done with GPS instead of kind of phones talking to each other through Bluetooth. Those GPS ones really did track you. It was hard to avoid sort of being tracked everywhere you went, since it was on a GPS technology. People didn't understand the distinction. And so this state-by-state approach, because it wasn't scalable, because states didn't have the resources to all put in money for an app, it sort of never took off. So that left us focused on the core public health institution of human contact tracing. So again, the way this works is when you have a positive laboratory test, the idea is that an epidemiologist will call you, figure out who's been within 6 feet of you for more than 15 minutes during your infectious period, and then we'll call all of those people, see if they're at risk, get them a test, and that's how we stop the outbreak, by isolating those folks once we know who the close contacts are. So the issue is that human contact tracing is labor intensive. And so starting in February, folks like the former head of CDC, Tom Frieden, and other Bill Gates, other folks around the country, did some studies that showed the United States needed about 300,000 contact tracers to handle the load of what they needed. A place like California, for example, needed about 30,000 contact tracers all on its own. We do not have anywhere near that number as of now in September. California, as an example, only has about 15,000 people. It's a massive number of contact tracers, but in terms of the population of California, it's not nearly enough for us to put in place a test, trace, and isolate strategy. And I'll remind you that the only reason to do something like a quarantine or a lockdown, based on the research that we looked at in the last lecture, is to buy you some time before you can implement other countermeasures like test, trace, and isolate. We sort of didn't use that time. We didn't build up contact tracers. We were too suspicious to use technology at a state-by-state approach. And because we didn't have a unified national approach to contact tracing or any federal funding or federal resources to support it, states went in vastly different ways that was confusing to the people about what was needed. And it's caused this kind of wave of disinformation. So the other thing to say about that is about testing and isolation. So in testing, we talked about polymerase chain reaction testing, PCR testing. At the beginning of COVID, most of the tests were being sent to laboratories, and they were tested on an individual basis. The backlog happened so quickly in testing in terms of March and April because healthcare centers really needed those tests to diagnose their patients, to figure out who was COVID and who wasn't. So there wasn't any testing capacity left over for the general public. Now, other countries solved this in a couple of ways. Some of them, especially poor countries in the Middle East and other places, immediately decided PCR tests were too expensive. So they moved to things like the saliva tests that we've seen, which are a little less sensitive, but will still, over 2 or 3 tests, give you some good certainty about whether somebody has COVID or not. Or they move to pooled tests. That is, you take a bunch of tests from like 100 people or 1,000 people, you put them all in the blender together, you see if any of them have COVID. If none of them do, then great. If you find COVID in there, then you kind of break the samples apart and you run everybody individually. These were sort of labor-saving and cost-saving improvisations that were done all over the world. We had a big enough PCR infrastructure that it wasn't something that the United States did. We didn't lean into those adaptive technologies. Folks like Abbott Labs put in place rapid tests and got out machines for that, but they also ran crucially short of reagents. One of the problems was at the very beginning of this, as countries were developing reagents, even though states do a lot of things in the United States, they don't develop laboratory reagents. That's left to CDC. CDC developed an initial reagent. That's kind of what a virus reacts with, so that you know it's there in a PCR machine. And the initial reagent that they sent out was flawed. It produced a lot of false results, and it took them then on the order of more than a month to redo that process and re-get reagents out. By that time, we had lost crucial momentum in testing and tracing and isolating the early cases that you might remember in Seattle, for example. We didn't have reagents available to test those cases when they happened. And so that set the stage for the explosive growth we've seen. Because states had really different strategies, data reporting mechanisms, skepticism about digital contact tracing, and other things like that, we were never able to sort of catch up on that momentum. And the last thing I'll say is in terms of isolation. So we've seen a lot of spread in places where a lot of people live in small places together, multi-generational apartments where a person lives with their parents and grandparents under one roof. That's really the core spread of COVID. It's household spread. You'll have a super spreader event like the funerals we've heard about, and then those folks who are infected will take it back, and usually they'll infect most members of their household, and so on and so forth. So for isolation to work well, you need a lot of free voluntary places that people can go to isolate themselves from their friends and family while they're safe. And usually our quarantine research shows that you need to make sure they're well fed, that their job is taken care of, that they feel confident in the state's response. So other countries put in place programs to keep employment in play to make people feel secure, set up sort of voluntary isolation tents or hotels. Some cities and municipalities did that in the States too, but because we didn't have sort of job protection programs, we didn't instill that same set of confidence. So our rate of people escaping from lockdown, sort of violating the terms of their isolation, much higher than other countries because of that uncertainty. Okay, so that brings us around to sort of the fourth point that I want to make, which is about public health messaging. So I said at the beginning of this, when I was talking about the history, one of Dr. Frieden and Dr. Red's main lesson from their 17 years of emergency response at CDC was that risk communication was key. Be first, be right, be credible, have a trusted health spokesperson who's out there giving one consistent message. In this case, we haven't had that. We haven't had clear and consistent messaging. One example of that was the initial call for people to wear cloth face coverings, which happened in April from the White House Coronavirus Task Force. There were three messengers there. I think Dr. Fauci from the task force themselves, the Surgeon General amplifying that message, and the president. And just purely from an evidence-based perspective, what the president said was, this cloth face covering thing is voluntary. Remember, it's voluntary. I don't think I'm going to do it myself. And what that created was an unclear call for muddled behavior. In public health, we talk about the effectiveness of interventions, and a public health message, a speech, an ad campaign, something like that is an intervention whose effectiveness can be messaged. That's why you hear public health doing things like putting calories on menus, right? Or putting warnings on cigarette boxes for tobacco control. It's because those messages actually prevent death. They make people eat less. They make people smoke less. They help people live longer. Even though it's just a message, it functions as a healthcare intervention. So similarly, an announcement that people need to wear masks is an intervention. And we know from good evidence what makes it more or less effective. If it is made mandatory, it's going to be more effective. There may be more backlash, but it will be, even if it's not enforced, saying it's mandatory will make it more effective. If it's not mandatory, having everyone recommend it, every leadership person really in a country recommending it in the same way will strengthen the effectiveness of that intervention. And you need to make sure that recommendation is sort of clear and consistent across all jurisdictions. So we've learned that sort of mask mandates work, right? In a state like New York, which put in a mask mandate, and in multiple other states, researchers have shown that when you mandate masks, about a week later, your COVID cases start going down. That's not true for any other intervention. It doesn't mean that masks alone work. You need a number of layered public health interventions in place, social distancing and all that stuff. But if you message them well as a cohesive entity and you mandate masks, it's simple and it's effective. So the issue was two things have happened. Because of the federalized nature of our system, we don't do sort of national calls for things, right? Think about even in like a hurricane evacuation. A hurricane is coming towards Florida, Georgia, South Carolina. All three states are going to issue separate evacuation orders and guidance. And that's generally fine. But when they're in conflict with each other, if there wasn't an underlying National Weather Service forecast that grounded those evacuation orders, it would be chaotic. Similarly, in this case, there was not a grounded underlying something like a National Weather Service forecast for COVID that the federal government was saying with unity. There were disparate voices. Those disparate voices at the federal level led to disparate voices state by state, so that you had a state like Florida giving much different guidance than a state like Georgia. Imagine if that happened in a hurricane. The consequences were no less severe here. And unfortunately, we actually have studies at this point that show that part of that distrust is anchored in presidential messaging, which is, again, I'm not trying to be partisan. As a public health professional, public health researchers have done studies showing that public health messages are the low level of trust in those messages decreases by about 40% when the president says them at this point. And that was not true at the beginning of the outbreak. You might say, well, that's just partisan. People listen to the president or not. At the beginning of the outbreak, people gave the federal government a chance. They listened. But what they learned over time, and you could track these numbers month by month, is that there were conflicts. People were saying the wrong things. People got it wrong on masks. They changed their mind. But even when the science got it right, people in the federal government were fighting against it. And so that led to an ongoing lack of trust. In a public health emergency, the lack of trust is sort of the critical failure. In military planning, you talk about the center of gravity, that thing which is the key element of an enemy's position that really is holding everything together. You always want your operations to aim towards the center of gravity. In this case, the center of gravity is public trust. And the United States really lost that public trust over 3 or 4 months, which as a public health professional is sort of tragic to see. But you can also look at all of these different capabilities that we've talked about, whether it's non-pharmaceutical countermeasures, testing and tracing, healthcare surge. And a lot of the issues that we saw are based on a lack of public trust and a lack of a unified national strategy. So those things just sort of weren't in place. So that's my sort of COVID breakdown in a few minutes. Lots more to say about it, but I think that sort of anchors it in the capability. In the next and final talk, I know you're thinking like, thank God, when is he going to stop talking? In the next talk, we're going to talk about some of the ethical dilemmas that were faced by both at the local level within healthcare institutions, but also the ethical dilemmas that are faced by us as a country based on this and how we're responding to them. So thanks a lot. I'll see you in talk 4.